Bienvenue à la session scientifique du Département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du Département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki ekoweshkad, akonongum egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eniagizijig, enikukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
Bienvenue, bonjour, welcome, hello everyone to Merch, Family Medicine Grand Rounds. My name's Doug Archibald. I'm the Director of Research and Innovation for the Department of Family Medicine, and I'll be today's moderator. We're very fortunate today to have two fabulous presentations. The first of which is by Doctors Taunia, Rifai, and Nathan Chiarlitti. Taunia's a family physician at our Ottawa Hospital Academic Family Health Team, the Civic Campus, where she's currently the unit director. She obtained her medical degree at McGill University and completed her residency training in the US at the Maine Department Family Medicine Residency Program. She has many academic interests, including reproductive health, office-based procedures, gender-affirming care, and planetary health. Nathan is a recent graduate from our Winchester program, and he is the 2024 winner of the Residency Scholarly Project and was recognized in 2022 as the winner of the DFM's Dragon Den Environmental Competition. Currently, he splits his clinical work between Winchester and Iqaluit. Our second presentation will be by Dr. Amy Hsu. She's a PhD faculty member at the DFM. U Ottawa Brain and Mind Briere Health Research Institute Chair in Primary Healthcare Dementia. Her research uses population-level health data to examine older adults' health and healthcare needs, especially in those living with dementia and needing long-term care. So I'm going to turn things over to both Taunia and Nathan, who are going to be talking to us about the Heat Smart project. So without further ado.
Thank you. Is my screen visible?
It's perfect. You're all set to go,
Okay.
Taunia.
Super. So hi, everyone. Thanks for joining this morning. Nathan and I are sort of the representatives of a large group working on this project, and we'll name everyone in a few seconds. But our project is called Heat Smart, Empowering Primary Care Providers to Safeguard Vulnerable Populations Against Extreme Heat. So we'll dive right in. So this is our entire team. It's a large team, but everyone brings their own special focus. And so part of Nathan and I's job is to give this presentation and talk to you about what your role could be in this project. So just to get things started, we're going to start with a little bit of background information. So the World Health Organization predicts climate change is the largest human health risk of this century. So, and of those, extreme heat events are the most common and the most deadly health threats to climate change in Canada. So that's where we're going to focus our energies with this study, is heat specifically, though climate change has many effects. When we think about heat and the effect on the human body, on our physiology, it impacts almost every system. So if you're talking about circulatory system, clearly if your heart is strained and you're not able to get the blood where it needs to go, you're going to have multiple impacts from that. If your blood vessels become more permeable, that creates problems, specifically in the gut, where you can release toxins, and that can cause infection and sepsis and all kinds of problems. So heat can be pretty devastating on the human body. It's particularly bad, obviously, when it affects the cognition and our brain function as well. So you forget to take your medication, you forget to drink water, you forget to do the basic things to take care of yourself. Again, looking at all of the things that climate change and general the environment, all those things that happen in the environment, including heat waves, tornadoes, hurricanes, floods, all these things related to climate change, heat waves are still the most deadly of all of those, as demonstrated in this chart. And then, sure, they're deadly, which is awful, but also there's a million other problems that arise from having these many heat waves increasing in frequency and intensity. So this is a study from Quebec showing that in a year, the visits to the emergency room due to heat-related morbidity was about 36,000 visits, and 15,000 calls to health hotlines relating to heat issues, 470 deaths. So it's not just the deaths. Obviously, the deaths are a huge problem, but it really impacts the health system. So thanks to people studying this and looking at the last 20 plus years of extreme heat events, we're able to say, okay, well, who's at the most risk, right? And then you've got your intrinsic factors. So people over the age of 65, young children, people with certain chronic health conditions. And then when you look at extrinsic factors, people living alone are at higher risk. People with lower socioeconomic status are at higher risk. People obviously with no air conditioning are going to be at higher risk. People experiencing homelessness are going to be at higher risk. So it's well understood who's at risk. We get some of this data from major heat events in the past. So in 2003, in Paris, there was a really bad heat wave where 15,000 people died in 1 week due to the heat wave. So those terrible experiences, at least people are looking at them and trying to gather, the data to help prevent those events. And then this is a chart looking at in the US, year to year, deaths due to heat events. And what this chart really points out is if you look at, the general population is that purple line on the bottom, and then non-Hispanic Black people will have a higher risk, and then even higher than that will be people over 65. So again, people are studying this to figure out who is most at risk, and so now we're going to try to use that data to do something about it. So again, this, the death in Canada over the last 20 plus years will be from non-accidental and respiratory mortality. And then the greatest risk, again, is for those over age of 65. The other interesting piece is cities with higher renter proportions do have higher death rates and more morbidity from heat-related events. So Montreal, Toronto, and Vancouver are the highest renter cities in Canada, and so they have higher death risks when there is a heat event. This is another extreme heat event from 2021 in British Columbia. where there were 619 deaths over 1 week. And if you think back to that slide of Quebec, it was 470 over a year. So that was a huge heat event in BC. 98% of the deaths occurred indoors. And that's super important because a lot of people think, well, I just won't go outside because it's really hot outside. But we don't actually know that being inside is necessarily safer for people who don't have access to air conditioning or don't have support from a neighbor or a friend. Again, 2/3 of the deaths were in older people, and most of them lived alone. And then the other high proportion of risk were people with chronic diseases. So that leads to the question, well, what indoor temperature is safe? And there are recommendations that it should be between 20 and 26 degrees, and that if you're exceeding 26 degrees for more than 1 hour daily, you are increasing your risk for morbidity. And then, so, okay, heat is bad. What about heat plus wildfire smoke, which can go hand in hand, as we know intimately in Ottawa? So it's very likely to happen. But the important thing with this is, okay, we're telling people who don't have air conditioning, when it's hot, get the windows open, get the breeze going, get air circulating. But if there's wildfire smoke outside, we're going to tell them to shut their windows. So the recommendations change when we think of additional risks related to climate change. So it's sort of, we have to combine those risks and make very specific recommendations to people. Same with electricity failure. So you have an air conditioner, great. Maybe it doesn't work if there's no electricity. Those with, oxygen dependent, or those who need a CPAP to be healthy. All of those things will impact the recommendations on how best to care for yourself during a heat wave. Same with, frozen foods. You need to keep the freezer shut. We need to have a backup plan for those situations. So I think the point of the first half of this presentation is just to point out that extreme heat impacts individuals, populations, but it also impacts the healthcare system, right? If everyone is home panicking, they can't get access to their prescription medications. They don't know, they can't access their primary caregiver or primary care providers. They can't go to work, or work is having problems because there's no electricity. It impacts everything. And so there is a branch in the Canadian government looking at this, at climate change, and they're trying to mitigate climate change, but also trying to adapt to it because it is, to a degree, inevitable. Health Canada has a program called Heat Adapt, and they had a competition for projects in 2024. And so a few people on our committee, I was not involved at this point, but put a lot of work into a large submission to that program. And that's how we obtained funding for this, this study. And so Nathan's going to present a little bit more about the study.
Awesome. Thanks for that introduction, Taunia. I apologize that I'm not on camera. You were lagging quite a bit during the first part of the presentation, so I didn't want to take any chances. But if I was to summarize the first part, I think you did an excellent job. The one thing is that, of course, with heat-related events, there's not only significant healthcare costs, but the obviously associated morbidity and mortality. And it really led to the development of this research question, which is, do patients who are sent tailored digital health promotion messages adopt health adaptation behaviors that they can protect themselves from excessive heat-related illnesses? Next slide. Just a brief overview of our study, and then I'll kind of get into the nitty-gritties over the next following slides. But we're using a clustered randomized control trial where certain patients, depending on the intervention or control group, will receive tailored messages about heat-related events. And then we're going to measure measure the effects of them potentially hopefully changing their behaviors after each heat wave. Next slide. So we're looking for 100 primary care providers in Eastern Ontario. And shamelessly, I hoped recruitment would start today, but I haven't gotten the go-ahead. So I'm going to say recruitment's starting next month. And if the primary care providers agree, office administrators will extract the patient name, email address, cell phone number, health card number from the EMR of every patient greater than 18 years old who are able to speak English or French, have an active email, and have actually seen their primary care provider in the last 2 years. With the help of one of two encryption companies, ClinicConnects or Qualtrics, I should say, the data will either be encrypted and transferred to Montfort's data facility, or will be kept encrypted at the office. Patients will then be sent a digital message to consent to participate in the study with an intake survey, which will go over medication, socioeconomic status, comorbidities, and really allow us to send tailored messages to these people. Next slide. So we have the patients, and I mentioned before that, or we have the physicians' rosters, and we have what I mentioned prior was a clustered randomized control trial, and it's clustered at the level of the physician. So each physician will, their entire roster will either go to the intervention group or the control group. The control group will receive digital health promotion messages on relevant seasonal topics. In the summertime, oftentimes it's about Lyme or tick bites or even rabies. And the intervention group will receive tailored digital health messages about extreme heat. Now, one really important part of Taunia's introduction is that certain patient populations, depending on comorbidities, medications, age, will be at a higher risk of heat-related events. And these people, identified in our project through just through the intake survey, will receive additional resources to help tailor even more specific heat-related adaptation behaviors. Now you might ask yourself, well, what if these high-risk people are in the control group? Won't they have that same benefit? And they will, just not during the study. All these resources will be provided after. Next slide. At least when I was first listening to this, like, how are they getting the messages? Is it through the EMR? Is it through a text? Am I sending them? Is the office sending them? And it's actually through CPIN. CPIN is the Canadian Primary Care Information Network, and it works independently of EMR. So whether you're on PS Suites or Oscar or Epic or Meditech, think of this as a completely separate information exchange system where people will receive personalized digital messaging about a vast array of different health-related initiatives or behaviors or events. And in obviously our case, it's related to heat. Next slide. Here's just like a small template of what patients would actually receive or expect to receive. This from the COVID vaccine. And you can see how, there's a customized messages, hyperlinks involved, and people can explore the resources available. Next slide. So we have the intervention between the two groups, and after the first heat wave, we'll be able to measure some outcome measurements, and the biggest one, or a primary outcome, is the adaptation of heat-related behaviors, heat safety plans, hydration and cooling stations for these people in the intervention group. Secondary analyses will also be analyzing emerge visits, as Taunia mentioned, prescription refills, primary care encounters, to see the effect that these small interventions can have on the system. The third pretty important caveat I would say is that because of those high-risk people who are identified in the intake survey, they will separately be evaluated based on their ability or potentially their behavior change on implementing some of those even more advanced heat safety plans. And finally, the fourth tier that was added in fairly recently is an assessment of the primary care practitioners or primary care providers who participate in the study, and their experience and knowledge in kind of being able to counsel on this topic or feeling comfortable in discussing it with their patients. Next slide. I don't want to say there was a lot of concerns, at least initially, but there was some from Taunia and I when we were thinking about this and thinking about how best to implement it for PCPs. Of course, the first thing that pops up is like, listen, it sounds cool. I love what you guys are doing, but we just don't have any time. And I hopefully want to reassure you that there actually won't be that much of a time commitment aside from generating the initial flat file with the patient's information, which can be completed by the administrators, like office administrators, in about half an hour. through the entire process, our group has people in place that can help troubleshoot things and expedite things along, so that there's minimal time allotment, I'll say, for the actual primary care practitioners. You might ask, well, all my patients are getting these random messages. Won't they call the office? In past pool studies that have used this type of technique, only about 1 in 2,000 who get the initial email will actually make a call or a message to the clinic for confirmation. In this day and age, privacy is obviously such an important factor in healthcare. And one thing that came up repeatedly is that we're pulling the patient's data, but it will be encrypted if it even leaves the office. As I mentioned before, there's 2 separate companies that can encrypt the data, which of course will help with de-identification. Now, if one quick caveat is the patients won't actually consent to having their data pulled. That's why the physicians or the practitioners will consent, but they obviously will consent to the study with the initial intake survey. And if they're not interested, they're not interested. The last point is that, hopefully we've convinced you that this is an important thing to consider. And you're thinking, well, how big of a roster size could I possibly need to help this project out? And only about 500 people, or I shouldn't say only about 500 people, patients are what we're looking for, ideally in a clinic that at least has 2 practicing physicians, just for the clustered study design. Next slide. Oh, of course, why, if we didn't do a good enough job explaining why this would be a good enough study to join, I'll just go over a couple more quick points. Maybe I'll skip to the bottom of the slide and the generous financial compensation that's provided for each primary care provider who agrees to the study. No matter if their patients are stratified to the intervention or control group, they'll receive $3,000. So not insignificant for the amount of work that we're anticipating. And then, of course, something that's kind of near and dear to Taunia and I's heart is the climate change advocacy. As primary care providers, we have an intimate relationship with our patients. We're kind of on the forefront of this big worldwide crisis, and it can really allow us the opportunity to take a bigger role in advocating of the importance of these issues, and having the foresight to see these people at high risk, if we can mitigate their chances of ending up in the ER, worsening their chronic conditions, or potentially death. Next slide. So just to wrap up, I sound like a bit of a broken record because Taunia said this a couple times. I've already said this a couple times, but I really want this to be clear that heat-related events carry significant morbidity, mortality, and cost to the healthcare system. And it really led us to think about, or our group to think about, how we can mitigate these issues by potentially sending digital health promotion messages, which are unique to the patients, to encourage them to adopt healthy behaviors in the wake of these heat-related illnesses or heat-related events. And if you are curious, I'll copy paste this hyperlink into the group chat as well. For any primary care providers who are curious about being involved in this project. Next slide. So thank you.
Sorry, just before we sign off, we did get approval for.
Oh, no way.
Yeah.
Okay.
So I just wanted to update you. We just got a message from Bill. So if you are interested, we are actively recruiting at this point, so you can write to us.
Bill, shameless for leaving us out to dry like this, but yeah, that's awesome. Thank you so much, Taunia.
Mm-hmm.
Thank you for everyone for their attention. We are happy to field any questions.
Yeah, thank you, both Taunia and Nathan. That's great. We do have some time for questions, so if you don't mind, I've got one first. You mentioned that you'll start the collection or the measures during the first heat wave. Just a heat wave, I know we get a number of them in Eastern Ontario over the course of the summer. Is it a set temperature over a set amount of time that defines a heat wave?
Yeah.
So health
Yeah.
units have alert systems that they are already in place. So they can see when a heat wave is coming, like a few days prior. And so they alert the local health units, and then that's where we're going to access that information.
Excellent. Okay, good. Thank you. All right, I'll open the floor. I think Gary had a question in the chat. Can you discuss the power calculations involved in the study?
I cannot discuss the power calculations in the study. We, if there's a specific question, I'm happy to relay it with our statisticians, but that might be a little bit outside my scope. Taunia, do you know?
No, same.
Yeah.
I can address it a bit. It's Bill Hogg. We do, as Nathan said, we do have a statisticians working on our team who did the calculations. The design is a randomized controlled trial. So we're looking for a difference between the patients that receive the intervention compared with those that do not. After each heat wave, they're sent a survey where they are asked, did you change any behaviors? And over time, because there's multiple heat waves over a period of 2 years, we anticipate up to 5 a year, that accumulates. So if at any point they are changing behaviors as a result of our information campaign sent to them by text and email, we get that information as reported to us from the patients. And then the comparison happens. The calculation shows that we can detect what we think is a meaningful difference if we invite 100,000 patients into the study, get 20% of them to agree to participate and consent. That's the number of patients we need, 20,000 patients in the study, and that we think will get the consenting right number of people if we successfully recruit 100 primary care providers. Is that what you wanted to know, Gary?
I think so, Bill, and I can see that Stephen has also put some more details
Good.
regarding the calculation
right.
in the chat.
Stephen's the person you really want to listen to. He's affiliated with the Research Institute at CHIO, and Stephen and Richard Webster there completed the power calculations for us.
Super. Any other questions for Taunia or for Nathan?
Just to finalize the plug, as we are actively recruiting, I asked in many ways to be sure. It really is, as soon as you give access to the database, you don't actually have to do anything at all as a PCP. So it's actually quite easy to join. There's generous compensation for the time that it might take your office to supply that database. But aside from that, I think it's pretty easy. So I would hope that people are interested and do write to us.
Wonderful. Well, if questions do come to mind, please post them in the chat, and maybe Taunia and Nathan, if you have a chance, you can respond in the chat. But thanks so much. Great presentation, and I'm sure that there will be a lot of good impact that comes from this in terms of the behavior change. So encourage everybody, sign up. Looks like a great study.
Thank you.
All right. Let's now move to Amy Shu, and she's going to be talking about a long-term care study. So Amy, whenever you're ready.
Thank you,
Over to
Doug.
you.
Thanks for introduction. I guess I just want to start by making the remark that, this is the one aspect I really love about being in DFM and in this space, because you can have a talk that's about climate change and challenges with heat events. And then now we're pivoting towards long-term care, which is also a population that's often affected by extreme heat, especially because a lot of the facilities are quite old. The heating and temperature control is not great, but also palliative care. So you really get diverse perspectives. So this is a bit of a hard pivot to a different topic. But what I think could be potentially helpful in terms of stringing these presentation together is to really think about tools that we can use to support and guide implementation of new novel interventions and strategies across different care settings. So what I'm presenting on today is actually kind of lessons learned from our experience of implementing a calculator, a digital tool for early identification of PAV care needs. It's called Respect, in home care and long-term care environments. And, I'm not an implementation scientist by training. My training was as a health services researcher, health economist. But over the process of attempting to implement something in a clinical setting and to scale and spread, I've learned the utility of using a framework-based approach. And I'm hoping that some of these lessons, some of these learnings will be helpful to you as well. I have no conflict of interest to declare in terms of affiliations with any for-profit or not-for-profit organizations. I am one of the principal leads in the development of the Respect Calculator, which I will speak to today, but we don't actually get any direct financial support for people's use of the tool. This is actually slightly out of date. The project is supported by an incredibly large and multidisciplinary team. We have, on our team, we have our health services researchers, clinicians, implementation scientists, but all the way to designers and web developers on the team. So it's a very diverse team, and it wouldn't have been possible without the joint effort of many who are listed here, but also some I forgot to add here, so I apologize for that. And of course, I just want to start by acknowledging our funders. From start to finish, this has been probably a 10-year journey from the development of the first algorithm to our now implementation. It wouldn't have been possible without all of our funders. So I will start by actually providing a little bit of context around implementation science. Many of you are likely familiar with the discipline and the concept within implementation science, but just in case this is still something that is fairly new to you, basically implementation science is a discipline, it's a scientific study of methods to promote the systematic uptake of research findings, especially evidence-based practices and intervention into routine care. And what we often see is that within health services research, health research, and clinical care, a lot of the evidence that's gained from clinical research is actually not implemented into practice, or often when they are, they face significant barriers in terms of their ability to scale and spread beyond a single site. And so really implementation science had emerge out of that as a field of study to really understand why there are these barriers to implementing a new intervention, whether it's for behavior change or in terms of organizational change, but also why there are barriers to scale and spread as well as sustainability. And I think implementation science actually has a fairly prominent, or should have a fairly prominent role in primary care research. We know that quality improvement projects and initiatives are highly prevalent within primary care. I sit on a number of grant review committees, and I see a lot of these applications come in. And even though I'm not an implementation scientist, I'm starting to realize the value in having that framework to guide some of these evaluations. So that's one of the reasons why I wanted to share our experience, to hopefully encourage people to really think about whether or not some of these frameworks could be helpful for them. And this is quite obvious from existing research. So this systematic review, actually a review of systematic reviews that was conducted in 2015, had identified 23 systematic reviews over a span of about 20 years. Each of these reviews had, anywhere between 15 to 100 papers on average that they are reviewing. So we're talking about hundreds and possibly thousands of interventions are introduced all the time within primary care. And one of the things that they did notice is that, while a lot of these interventions were effective, there are significant challenges that are noted in many studies in terms of their ability to scale and spread these interventions. So it's great when we have positive finding with any implementation research, but sometimes even when we have positive findings, we don't really know why it worked. We just know that it works. And I think that's one of the reasons why implementation science has such an important role in helping us understand why something actually worked. And on the flip side, when the intervention doesn't work, this is also where these frameworks are helpful in helping us understand why the intervention or the strategy that we had implemented did not work. And so there's strong implications for sustainability as well as scale and spread of a lot of these QI interventions. So the particular intervention that I will be using as the example kind of throughout the presentation this morning is called RESPECT. The RESPECT calculator was developed out of our team's initial collaboration with community providers in home care and also primary care, where they identify significant knowledge gap, but also a lack of tools that could help them prognosticate or provide some data on the life expectancy of frail elders living in the community and not knowing when to activate or initiate palliative care or palliative care referral. So because we have access to this really incredible data warehouse in Ontario, which is called ICES, we are able to actually pull data at the population level to look at what happens after a person has an encounter with a healthcare system and looking at their trajectory. And so initially, the project, like I mentioned, was really focused on the community setting. We use province-wide home care data to look at what happens after an initial assessment was done. And from that point forward, what's the life expectancy of that person who has entered home care? And then using that to basically predict and help to prognosticate their life expectancy or their survival risk. And our first algorithm was actually implemented as a web calculator. The link is here. I'll also post the link in the chat here. So we implemented the first version of our algorithm as a web-based calculator that primary care providers as well as home care providers can use to kind of guide their understanding of their patient's prognosis and then potentially activate referrals to palliative care. Since then, we have actually adapted our home care or community-based care calculator for usage in the long-term care population, where the baseline risk is slightly different. They're more frail, medically complex, and just have a higher mortality risk at baseline compared to the community population. So we have now adapted a version of RESPECT for long-term care. And that's the part that I will focus on for the rest of the talk. So with the RESPECT calculator, what individuals going to the website, but also our home care partners as well as long-term care partners get are these individualized reports. So these individualized reports are essentially reports that can summarize the patient's mortality risk as well as their life expectancy. And we also provide kind of an overview of their functional capacity. So each of these reports basically reflects a risk spin that the algorithm is generating, and it's tailored to the person's characteristics at the time of assessment. So the language that's presented here and that we often use is for people like you in Ontario, this is what their function, their functional impairment or functional capacity looks like. This is their level of cognitive impairment. This is what their life expectancy looked like. You would see that on the section 3 on the right-hand side there. where for someone who is in our highest risk bin, the survival could be as low as 3 weeks, and it could range between 2 to 4 weeks. But in our lowest risk bin, so people with the longest survival, the average life expectancy is actually 8 years. So it could range from 3 weeks to 8 years. And we have these risk bins that are created reflecting the different patient profiles, and individuals will get these personalized reports that they can use where, whether it's with a primary care provider supporting their care, or in a long-term care setting, the entire clinical care team will have access to this report. So as I mentioned, this is implemented in home care in the Ottawa region, but also in several long-term care homes in Ontario currently. In addition to our calculator and this personalized report, we actually do provide training in terms of helping clinicians conduct serious illness conversations. And this is one of the things that we actually learned from the first iteration of our implementation. So this is why, again, the framework is really helpful, because going through that process, and this is often the case for any new novel interventions, the first step is to ensure individuals have the knowledge and the skill to actually carry out the intervention that you're asking them to deliver. And one of the things we noticed was that providers were coming to us to say, yes, it's great that we have this calculator, we have this prognosis, but I don't really know how to share this with my patients. And so we actually had adapted our implementation to add the serious illness conversation guide, which is a communication guide that clinicians can use. It's scripted, it's patient test language that clinicians can use to have a conversation about critical illness, about the patient's expectations, sharing prognosis in this conversation as well. And then also kind of ending up at a point where you have a good understanding of their values and their wishes so that you can move forward towards developing a care plan for them that is aligned with their preference and their wishes. And so in addition to the implementation of the calculator itself, we provide training on how to use this communication guide. So the evaluation, what's really interesting is that it wasn't a single framework. We actually used multiple frameworks to guide this process, which for me personally was quite daunting at the beginning. A lot of these implementation science frameworks have anywhere between 10 to sometimes 30, 40 domains. So when you look at these frameworks, initially it could be very overwhelming and not knowing what to implement and what to focus on. And I think this is where we were really fortunate to be surrounded by really leaders in implementation science here within Ottawa that helped us to identify the right frameworks and then tailoring the adaptation of those frameworks to our implementation project. So the first framework that we used, so I'll actually kind of highlight 3 main ones that we used in our research. The first one is the ACT framework. And basically, it just spells out action, actor, context, target, and time. And all this, what this framework does is that it tells you who is doing what and when. And it seems quite intuitive. But a lot of times, I think when we're going through this process, there's a lot of stakeholders that are involved in the implementation. And when you don't have a systematic way to identify these individuals, sometimes you can actually miss a key contributor to the process of implementation. And so this really helps, using a framework really helps us to understand and really follow the action, right? So you start with the core action that you're trying to implement. In our case, the core action is running the calculator and then having a conversation about the prognosis with the patient. So the action is sharing this prognosis, and then you have to identify the actor who is sharing this information, who is generating the report, and how often are they having these conversations with patients and possibly their family members, in what context, right? When do these conversations arise, and then how frequently? And so it was actually really helpful using the framework because it also suggests the questions that we can use in our evaluation. So when we're going to, I don't know about you, but often I'm not a qualitative researcher by training. I'm a quantitative researcher. So when I'm approaching these qualitative projects, sometimes I don't know if I'm asking the right question. And if you don't ask the right questions, you could get a very superficial answer, or it could be completely misdirected. And so these frameworks helps you to really narrow down and ask the right questions that are related to your implementation. They give examples about exactly what these domains and constructs are meant to target. And then it really helps you to ask the right question when you're trying to identify who is involved in the implementation and what the process should look like. And what we ended up with actually is quite practical from the application of the ACT framework. What we ended up with was this process map where we were able to take all that qualitative data and identify individuals along the pathway. So individuals who might have any interaction with the process of having these care conferences and communicating prognosis to the long-term care resident and their substitute decision makers and family members. So we identify all these individuals, we map out the process of what they're doing and when, and then it helped us to identify a point of intervention. So when can we actually use respect? Where is respect most likely to be effective within this process, and how will people use it? So even from just using that one framework, it helped to provide a roadmap for how we're going to approach our implementation. The second framework that we used was a theoretical domains framework. It's actually quite commonly used in any sort of interventions around health behavior changes. So it helps to identify personal level barriers. As you can see, there are 14 domains as part of the TDF that covers things like knowledge and skills, which are often the basis of where you start an intervention. But then you also get into the process of decision making. So what is important to the person for whom you're trying to change the behavior, and really trying to influence that process. So one of the things that was really helpful for us was one, clinicians often experience anxiety when having these conversations with patients and family members, because critical illness conversations are not easy conversations to have. And so really using this framework and developing the interview guide helped us to probe more into that and really understand what are these emotions that they might be experiencing when having these conversations. What are some of the motivators for behavior change? So for example, if they believe that this is going to have an impact in terms of the quality of life or quality of care for the patient, beliefs about consequences, they're more likely to change their behavior. So again, we kind of use this framework to kind of help us identify what exactly we're asking the person to do and change about their behavior and their practice. And then again, using the TDF and then linking up to other frameworks and taxonomies of intervention that really helps to target these specific barriers. So there are other tools that kind of help you to think about how do you tailor or how do you tweak your intervention to address the specific barriers that are identified by the individual users that you're intervening on. And then finally, sort of a higher level framework is a CFR. It's a consolidated framework that actually does encompass like an inner domain where it focuses on individual factors, but we really use it to kind of look at the outer setting, the resources, the context, what will influence the success of our implementation. One of the things that we unfortunately learned in our initial implementation was policy changes and governmental changes. Elections tend to delay implementation projects. And when there's a change in government, change in direction, it will also then have trickle-down effects. And so if you're only really focused on the individuals or even a single organization, you may forget to kind of probe and capture some of these outer settings, these contextual pieces that are important to the implementation that have an indirect effect on the success of your intervention. And so this was really helpful in kind of helping us to map out, again, policy changes, things that we need to track, be aware of, and potentially additional people and stakeholders we need to reach out to, so then we can ensure the success of our implementation. And then what we did was we actually built a multiple case study approach. And so we initially kind of applied the framework to a handful of homes. And then we use that to kind of create our code book, to kind of create these cases. So we have essentially 3 to 4 typologies of long-term care providers that have similar characteristics, similar sets of challenges that then help us to develop tailored strategy. So this is actually not, I guess, a visually appealing slide, but basically we created these case vignettes that help us to really identify what makes, what's unique about this type of environment, what are some of the barriers that we have identified, and what are the strategies that we can then integrate into our implementation package, our implementation, our intervention in order to make sure that it's successful. So using this multiple case study approach, we built these vignettes or cases around a handful of homes, which we then validated in other long-term care homes in Ontario. So over the course of the past 2 years, we actually have conducted 31 interviews, 11 focus group, which doesn't seem like a lot, but there's actually hours and hours of data that's collected across 8 long-term care homes where we have essentially refined these typologies that we are now going to replicate and validate in long-term care homes in Alberta. So we're very fortunate to recently get funding through a CHR project grant that allows us to do this replication, this validation exercise in Alberta to see whether or not our understanding of how this intervention works can in fact scale and spread to a different environment. And because we use these frameworks, it was actually really simple to think about how we will scale and spread because we basically took the same set of interviews and surveys into a new environment, and then it just allows you to compare and contrast on the same domain, the same construct. So you're capturing the same thing in a different environment and really helps you kind of test your hypotheses in terms of what will make this a successful intervention and what are some of the barriers you want to anticipate and mitigate. So we're in the process of, as I mentioned, in this scale of spreading, but I think I just wanted to kind of share some of our experience because I initially, I think was, I don't think I was reluctant to try the frameworks. I was just very intimidated by this framework-based approach. But going through this, I really understood and learned the utility and the value in using that approach, especially when you're thinking about developing an intervention that could expand beyond a single clinic or even a single region. So those are my slides. That's my presentation. I could take questions if there are any.
Amy, thank you so much. Great presentation. And thank you for, for bringing in implementation science. I mean, often when we think of research, we think of the knowledge of discovery, but really, I think a very important element, especially in primary care, is the knowledge of integration and the implementation of the knowledge of implementation, essentially. I mean, if we look at Boyer's scholarship, domains of scholarship, absolutely. I did have a question with the frameworks. As you mentioned, the first framework and the ACT framework, very qualitative, where you found the framework very helpful in creating questions. And then I would see the other two frameworks very much for building out. And you've used a multiple case study approach. I'm just wondering, are you referring to Robert Yin? He's done a lot of work sort of in that domain of multiple case studies. But I mean, there's a number of sort of theoretical people involved in case studies. And just wondering who you're referring to when you're referencing your case studies.
Yeah, so I think actually the one thing that I forgot to add is that it's not entirely qualitative because some of these frameworks actually do have data collection tools and there are quantitative surveys that can be adapted and administered. So not all of it is qualitative. If anyone is also not a qualitative research like myself, and it's going to worry about doing all these interviews. So some of it, I think, can be converted into surveys. We did actually have a survey for capturing the training experience. So we did adapt some of these tools for that quantitative data collection analysis as well. In terms of multiple case studies, Doug, I actually am not familiar with Robert in. There's a few, yeah, so there's a few papers that we kind of build our strategy off of, but I would love to get the reference if you.
Oh, for sure. I think Robert Yin is someone to look at because he has really embraced both methods, like qualitative measures for case studies, but also embracing quantitative measures as well, specifically for multiple case studies. Whereas someone like Robert Stake, for example, very much sort of the case study, traditional case study approach, very qualitative in nature. So absolutely, I'll send you some of his stuff, and there's others since then. But for sure. And I'm glad you mentioned this too, because I think that, yeah, with the qualitative, right, it's very contextual, it's very individual, right? Not worried so much about generalizing the data. So, you know, embracing both, you know, both the qualitative interviews, focus groups with more quantitative measures. I think it's a great approach. So thank you. So anyways, we've got lots of time for questions here. So please, folks, any questions for Amy, please let her know.
Oh, Sophie. Hi, Sophie.
Hi, Amy. Thank you for the presentation. It was very interesting. And Doug, I would be curious where the recording will be available, because I think that this could be really valuable for many members of the Ontario Centres for Learning, Research and Innovation team. My question, Amy, is what motivated your team to go in the scaling and implementation? As Doug said in his wrap up, is, you know, researchers are often interested in filling a gap in knowledge. And so you went one step further and want to do a very robust understanding and research on the scaling. So what motivated you?
No, thanks, Sophie. I also want to first mention that the Ontario CRI has been an instrumental partner in a lot of our work. Right. And so part of that scaling is facilitated by great partners like the Ontario CRI, who's connected with long-term care homes across the province. I think part of it, there is an aspect of it that's organic, because every time you know that there is a successful intervention that you develop or introduce, and you share this with others in your community, naturally there will be some interest, right? And I think this is where, how do you convert that interest into action so that someone else could actually take what you've done and then implement it and then replicate it? And so I think this actually happens a lot within primary care, because we hear about these great practices. And the organic part was that when we developed the tool, there was a lot of, you know, long-term care homes where they recognized this is a gap that they had in their practice in terms of a tool that they can use for early identification palliative care needs that came to us. And we realized we needed a robust approach to move forward with all these requests that are coming in. But also, I think just from a scientific academic standpoint, I spent many, many years developing this solution, and I don't want it to be limited to a single site. And so I'm always, you know, thinking about how we can successfully scale and spread.
Thanks so much. And I wasn't fishing, but yes, the partnership has been extremely valuable for our team too. But I in the meantime, I pulled up the website of the Centre for Effective Practice. So there are these organizations in Ontario that's their mandate to do the type of work you just described, Amy. So I think when it's a marriage made in heaven when a researcher's passion and the mandate of a sort of a scaling organization meet, and then success can happen, and we can move away from the land of pilot projects to actual practice change. So thank you.
Well, again, great presentation, Amy. Just keeping my eye on the chat here to see if there are any more questions. just want to remind people if they can complete, we are doing an evaluation of rounds. So you can see in the chat, there's been a survey that's been put in the chat. So just click on the link and fill out. We'd appreciate it. As you all know, rounds are accredited. You know, to keep that up, we need to continually improve the program and find out what you're interested in hearing, that sort of thing. So please complete that. Anyways, with that, I will wish you all a good day. And just a reminder that our next Family Medicine Grand Rounds, April 24th, we'll have 2 speakers, Doctors Lisa Z and Sophie Turcott. So with that, enjoy your Thursday. Bye now.